Bore da pawb. Mae'n blessing mawr I croesawu chi heddiw. Good morning, everyone. It is a pleasure, a privilege, and an honour to be chairing this morning's session and to welcome you here today. I used to be Chair of Public Health Wales until about, till up until last August. And in fact, I had the honour of being the chair of the forerunner of this network. And so I'm glad to be coming back and joining the fold. My name is Mansel Aylward, and I'm working now as the chair of Life Science Hub Wales, which is linking up with the NHS. I'm also chair of the Bevan Commission, which had a wonderful international conference last week, and I do a little bit of research still in Swansea and Cardiff universities. But much of my time had been involved away from my home in Wales, in London for more than 20 years, and during that time I was heavily involved in looking at policy in regard to mental health and indeed propagating the psychosocial paradigm which had fallen into, well, not into disrepute, but had fallen by the wayside since it was first introduced in 1960s. What I'm going to do today is not give you a brief overview of what's going to happen or even talk about in any way what the key issues are, because the people we've invited to speak today and the workshops and yourselves probably know much more about this than I do now. But what I want to do is to give you a little what I call homily, a little narrative about my sort of feelings about mental health and health in general. And I want to take you back to the time when Homo sapiens sapiens, the subspecies of Homo sapiens, and we are Homo sapiens sapiens, when they first emerged. Now that may be something some people say only 600,000 years ago, others say it's over 1 million years ago. But the characteristic that distinguishes Homo sapiens sapiens from Homo sapiens is that Homo sapiens sapiens, I'll stop using this in a minute, Homo sapiens sapiens is known to have had what's called reflective consciousness. That person, Homo sapiens sapiens, knew that they knew, were aware of their surroundings, could think of the future and plan for the future. And they wondered why there was a moon that went one way and a sun that went the other, went up and down, and there were seasons, and they wondered where the wind came from. So they were concerned about their environment, and they wondered, why are we here? And there are paintings left on caves which demonstrate the sort of thought process they've had, and the work that's been done by psychologists and anthropologists suggests that this is the case. Reflective consciousness, being aware of your surroundings fully. The earlier Homo species had some elements of that, but it was Homo sapiens sapiens which had that reflective consciousness. So whenever you are concerned about why you were here, and when you're concerned about what the future might hold, it's pretty natural to be rather worried, timid, and perhaps fierce, afraid. Being anxious, being fearful, being timid, worrying, and being less than bold were the single important characteristics in the mind of Homo sapiens sapiens. Why? Because if you didn't have those characteristics, one false step and you were dead. So that was one of these are the characteristics that probably helped us to survive to today, and we still possess them, because these characteristics we know are partially transmitted genetically and partly transmitted by what they call MEMS or memes, behaviours passing from one generation to another. So it isn't a concern of ours to worry about being depressed or anxious or worried, because if we weren't, we wouldn't be here. Or if we were, we wouldn't have been as successful as we should have been. Now, alongside that, and this is my theory, so, others have written much more about it, but my theory is alongside that anxiousness and fearfulness and sadness in some areas and timidness was not survival of the fittest, which is what Darwin pronounces, and it is correct in the sense of what we mean by fit. But actually, there's more and more evidence now that our survival in early species and in other animals, higher animals, was actually because of group survival. Because of, although we had these individual characteristics which helped us survive as individuals, we survived, as did many of the higher mammals, because of group. Collaboration and cooperation were much more important than being fit in the healthy sort of way of running away from things and all the things that we think of as survival of the fittest. It may have been appropriate for other animals, but people who think and people who want to work together, survival of the group is very important. And particularly if the group all possess the same characteristics of being anxious, worried and timid. Group survival, collaboration, group feeling, and considering the group as an extended family. That's another element of reflective consciousness. And thereby, empathy, compassion, and involvement with the group was very important. And one of the involvements that we know helps us all is if we're doing something which you think is worthwhile, if we've got a good job, if we're contributing to society, it makes us have greater self-esteem. And those anxieties and other feelings are tempered by that being in work. Now, I was recently involved with a film that was shown on television last week, or the week before last actually, called For All the People. And it was celebrating the voice of the NHS, celebrating a day in the life of the NHS, and was written by Owen Shears, the poet. And it was actually filmed mostly at Aneurin, Bevan, and in Neville Hall Hospital, where Owen was born. And when I had collaborated on another film with him the year before last, and when we were talking about the film and how he was going to address his poem, which is like Under Milk Wood type of poem, he said to me, "How did this all start? When did healthcare begin? When did this happen?" And because I had this theory anyway, and I had it for a long time, I felt that there must have been one time, when Homo sapiens sapiens was aware that a stranger had a wound, or was ill, or was under the weather, and attended to them. And that must have been the beginning of healthcare, right, in principle. And he coined that, turned that into a wonderful statement, which I can't remember fully, right at the beginning, when Michael Sheen is a reporter, and he's talking about, well, how did this all come about? And he uses words like, and these are not the right ones, it was the time when someone put his hand to calm the wound of a stranger. Isn't that wonderful words? That's not the right ones, they're not as good as Owen's. But the thing is, empathy, compassion and involvement was so very important for our survival. And in that, linked into that, my feeling is that doing something worthwhile for the group helped to counteract the other feelings of fear and timidness and sadness and just general worry. That's my point. So I start off by saying work, however we describe it, has that characteristic. You are contributing. If you have a good job, you are content. People who work longer in good jobs live longer. I'm not going to go into all of that because that would take far too long, but the evidence is there. So there were two factors working alongside our evolution. One was individual survival and tempered by group survival, but group survival probably was the most important reason why we are here today. Until perhaps the last 100 years or so, happiness, for want of a better word, or you might use well-being, but I use happiness, because neither of them can be well defined, was the preserve of the rich and the mighty. Look back. Unless you had money, unless you were of a particular social standing, life was short, brutal and nasty. Now somebody famous said that, but I can't remember who they were. But it was. And therefore, it was very rare that people were happy in the sense that we knew it. Very rare they talked about well-being. All they were concerned about was survival. The majority of people had no roof over their head. They didn't have enough money they didn't have any money. They didn't have enough food to eat. They were insecure. And did they have any times of happiness? Probably yes, when a child was born, probably when they had a marriage ceremony or whatever it was. But happiness is a new thing. It's not an old thing. The Bible writes about happiness and how joy can come into life by believing in God and all that stuff. But you had to adhere to the 10 Commandments, were pretty stiff to do that. But anyway, so happiness isn't something that people say, oh, people are unhappier nowadays than they were 20 years ago. No, they weren't. All the evidence shows that there's not been much change in happiness since we all had a welfare state, since we all had a living wage. That's what made people happy and contented, because they had time other than working grudgingly at awful work. I come from Merthyr Tydfil. There, as in other parts of Wales, where the ironworks and the coal mines were, it was appalling to live in those times. And before that, in the Middle Ages, it was probably even more appalling. So happiness is something that is quite distinct, and may well be. That's why we sort of are so involved with it, in that when we do feel happy, when we do feel a sense of well-being, it makes a vast difference to our lives. And what we're talking about today is mental health in the workplace, the evidence base. And that's so important in the light of this historical attempt to explain things. I still have a couple more minutes to go, as I've been given 15 minutes. And I'd like to talk a bit about how I got involved with mental health. I wanted to be a surgeon. In my days, there were all these programs on television, Dr. Finley's Casebook and Ben Casey and all these sort of people, and that fellow who was always looking beautiful. I can't remember his name now. But they were all surgeons and they did wonderful things, and I wanted to be a surgeon. Until a day arrived on the 21st of October 1966, when by pure chance I happened to be in Aberfan, because my family lived in Aberfan. And that experience for 2 or 3 days changed my life, changed the way in which what I wanted to do in medicine. And I came back to Merthyr Tydfil, and I became a general practitioner, and I was involved with the treatment of those parents and relatives of the children that had died. And my family lost 2 children as well. So I then realised how very important the mental health area was compared with all the others. It knocked all the others into a cocked hat. If people were mentally unwell and distressed, even if they didn't have caseness, we talk about, schizophrenia and all these sort of words, that's not the important issues. We know how to manage them. It's people who are failing to cope, people who find life difficult, people who have bereavements, people who have stresses. That's what I consider as the major problem that we have to tackle. And I tackled that in the 1970s, and it got my interest, and I did some work on depression in South Wales Valleys in relationship to Aberfan. And personally, at that, much later, this thing came along called post-traumatic stress disorder. I don't believe in post-traumatic stress disorder. It's a nonsense. It was made up by the Americans so that the veterans coming back from war could get free health care and welfare because they had a diagnosis. But I do believe in psychological trauma. And I didn't, from that day in Aberfan until just 2 years ago, I used to wake up at night with terrors. I used to have flashbacks. I used to feel extremely depressed around and about October every year. And I thought it was normal. Because I thought if anybody had seen what I'd seen and just shunned away from it, not shunned away, didn't remember it, didn't have an impact upon them, that was abnormal. So to me, psychological trauma didn't harm me in any way, because I thought that's the way a normal human being within the human condition should behave. And only when the Aberfan 50th anniversary came about in 2016 did I come to terms with it. So mental health means a lot to me personally, its causes, its treatment, its management, and it means a lot to me in the work that I've done. Last of all, one other element which made me think twice about what happens when people are mentally unwell. When I was Chief Medical Officer in London in the early 90s, I noticed that many of the people who were on benefits, not just incapacity benefits or invalidity benefit then, were suffering from what were really common health problems, not major things, but common health problems. So we looked at the type of common health problem that people had, and we noticed that actually of those, in percentages, 60% of people had back problems, and that was the reason why they were seeing their doctor, GP, and that was the reason why they were off work and receiving benefit, or off work and not receiving benefit. And I wondered, why was that? So we looked in that in some really great depth with a late friend, professor of mine called Gordon Waddell, who wrote a book called The Back Pain Revolution as a result of this. And what we found was that if this kept on going, it was almost exponential, that everybody in Great Britain would be off work because of an illness, and 80% of them would have backache. Now that was a nonsense, was it not? So we looked into it in depth, and we looked at people in the street, and we interviewed people in the street and found out, had they had these symptoms in the last 3 months or so? And then we did it again in Cardiff when I returned to Wales 10, 12 years ago. And we found that the distribution and severity of symptoms in the normal population was very similar to the nature and frequency and severity of symptoms in those who were going to their doctors with common health problems. And we wondered why that was. And then we realised it wasn't why do people have common health problems, and that includes a large segment with mental health problems. It's not why, but why do some people recover when others don't? Because that's the thing. And then just a bit later, in the late 1990s, I saw something that I could not explain, and that was, over a period of 3 or 4 months, getting the returns of people's reasons for going to their doctor. We were doing sampling, and we had all the data on people who were being given a diagnosis for being off work. We found there was a change. Back pain was no longer the main problem. Back pain went down to about 15 to 20%. But the diagnosis now was a mental health problem. Now, was there that change? Could people suddenly say, well, or did something happen which said, oh, well, my backache isn't a problem anymore, it's a mental health problem? Well, of course, I can't go much longer because I haven't got the time. I'd like to go on all the morning. But what we discovered, of course, was that people were then able to describe their problems in a mental health context. They would not believe that they were mentally ill because they weren't. They didn't even have caseness, but the majority of those people with common health problems, and particularly with backache, that was not the reason. Those old diagnoses were not the reason why they were not functioning well, not in work, and going to see their doctor. It was because of their beliefs and the attitudes and the environment. So I moved from being a medical model person, everything is, the body is a machine, and you just mend the machine or put in new parts and it trundles away. That's the medical model. It's done some wonderful things in history and still does. But actually there's much more to do with the personal psychological attitudes of people and their beliefs. And we tackled those. Won't go into it, but that was part of my work when I came back to Cardiff. But more recently, having been involved in public health, what I realised that the single most important reason why people have common health problems, why people get depressed, why people don't go to work, why people are unhappy, is because of their social status. The socio-economic spectrum is so important. Poverty is still with us. It may be nothing like we had in Dickens's time or earlier, but it's still with us because it's relative. Insecurity is still with us. All the factors that promote discord are related to where you are on the socio-economic spectrum. And so I've gone into that in much more detail, and I find that the social causes of the biopsychosocial model, probably the social and where you live and how you live and your family life, are so far more important. And at the heart of it all is poverty. Not abject poverty, but relative poverty. And that is shared by a big friend of mine who may know and came to talk to us last week, is Sir Michael Marmot. Has anybody not heard of Michael Marmot? Well, there must be some people who never heard of him. Who has heard of him? Come on, be honest. Yeah, well, you know, he believes that too. So I know I haven't addressed all the issues that are going on today, but I thought I'd give you that little chat to give you my sort of feelings about it all. In fact, I'm glad I'm doing that, because actually, when you look at the people we've got in the workshops, quite clearly you're going to go through all the sort of key issues that are needed to be dissected and discussed today. So I won't dwell on the key issues which need to be thoroughly addressed in the workplace. Others better qualified, as I said earlier, are doing that. Indeed, this seminar is an important one because it is addressing the evidence base. Another big talk that I gave about evidence-based medicine and all that sort of stuff. Sometimes badly used, but when it's used well, the evidence base really informs us and helps us to have better practice and greater outcomes achieved. Now then, I am now going to introduce Dr. Adrian Neal. Now, we've had a chat beforehand. We never knew each other before, but we've got such a lot in common. Dr. Adrian Neal is a consultant clinical psychologist with a background in organisational psychology and head of employee wellbeing at Aneurin Bevan University Health Board. And he's current chair of the British Psychological Society's Division of Clinical Psychology, Wales. That's where the Wales came on, right? He has published and researched in the areas of mental health, psychosocial workplace, well-being and organisation culture. In fact, all the relevant things about which he is specialised in talking today. And psychological models of leadership. That is an important area for me as well. He's going to be actually talking about, what are you talking about? I am going to... Oh, here we are. I'm useless at these things. I don't know why people ask me to do it. Anyway, what does evidence-based practice really mean when thinking about mental health at work? Now, there we are. I give you a good introduction to that, didn't I? So, coming up, and you've got 25 minutes. I will do that at 2 minutes, okay. Right? And at 1. Okay. Welcome. Thank you.
Borodar, good morning. Nice to be here. Thank you for inviting me. I kind of struggled to follow that, to be honest. But, you know, I'll try. I'm a psychologist. There are many different types of psychologists, but I just collapse them all into one group, really. And as a result, I'm very much a fan of the biopsychosocial model, but my knowledge lies within the psychosocial. So if I make less acknowledgement of the bio, please forgive me, but that's really not my area of expertise. So that's my disclaimer. Okay. What I'd like to do really is just to talk you through. I could have gone down two routes with this. I could have kind of presented one massive literature review with tables and bored you to death, which sometimes works, but actually is not particularly engaging. Or I could have, I guess, gone down the route I've chosen, which is to really seed some ideas and to get you thinking, maybe something slightly differently. Although some of the conversations I've had today makes me think, actually, I'm not thinking that differently. A lot of people are thinking very some way. So what I'm really wanting to think about is the psychosocial evidence for promoting well-being and therefore mental health at work. Okay. Ooh.
Some people in the back are struggling.
All right, Bill. And this feels like a White House press conference. Especially this one. This is terrifying, this one.
Is that better?
Yeah. Is that okay? Shall I... I'll crack on and see what happens. Okay, so... Ooh.
Sorry.
Oh, brilliant.
Sorry, I don't think it will...
Okay, fabulous. So I just nod in.
nod.
Excellent.
Okay.
Put my hands in my pockets now. Right, so mental health, it's as a phrase, it's common and familiar to us all, but actually we're not particularly well socialized to what it really means. Okay, and as a result, understanding to me is the bedrock of everything. If you don't understand something, then how can you make sense of it? How can you work with it? How can you change it? So actually, we're not socialized. Now, it's music to my ears that there are schools, there are educational systems that are starting to help children understand about emotional well-being, the importance of their feelings. But us, as a cohort, we did not have that. So the vast majority of our population, thinking about mental health is often unfamiliar territory, even if you've experienced mental health difficulties. And that's part of the challenge. So what we're really talking about, is it just a diagnosis? Mansel mentioned his feelings about PTSD. Are we just talking about labels and disorders? So, what actually is mental health? Are we talking about a spectrum where you have, health on one end and illness on the other, and you have to get to what Mansel described as caseness to have some sort of sense of acknowledgement of that difficulty. And if you're not sure what caseness means, it's simply that you meet clinical thresholds to then meet diagnostic criteria. So it's quite a medicalized way of thinking about things. But actually, our mental health shifts all the time, day to day. It's far less kind of a rigid construct as we think. Okay. And again, if we don't understand our own mental health, how can we actually help others, friends, family, colleagues? So there's some fundamental issues that we've really not got to grips with yet when it comes to understanding and improving people's mental health and emotional distress. We've all heard this one, if only I had a broken leg. It's so much easier to have something tangible, something that is explicitly recognizable as an illness. Mental health doesn't tend to fit into that category, which is the problem. And often we use physical health as a yardstick to understand mental health, and therein lies a fundamental problem. It is far more complex. And it's not only complex from an understanding how it works point of view, it's complex because you add the social stigma and the social constructs around mental health, which just complicate matters. So that wonderful cognitive ability that Mansel was referring to, which is what we'd call metacognition, that ability to think about your own thoughts, to have consciousness, is amazing. But there's a curse as well, because we can often get over involved in our thinking about ourselves, about our internal states, and you kind of get wrapped up really quite viciously sometimes. So, that's another aspect of mental health which people often don't think about. Okay. So, a little bit of evidence. I have gone to some evidence. So, recent CIPD survey. Everyone saw the survey, CIPD survey? Okay, really useful document, very current. And this is just a snippets from it, basically saying people are reporting that there are more issues with mental health at work. Now, what that actually means is harder to define, but either it's people are just becoming more aware and therefore reporting it, or they're actually things are getting worse. We're not entirely sure. But things like presenteeism, which we all know is basically coming to work and you're not well, you're not functioning, whether it's because you have something contagious or whether you just are not operating cognitively, emotionally. Leavism, which is a new one to me, which is basically taking leave because you're worried about activating your sickness absence policy, which to me is wrong. But it's happening, it's going up. A general increase in common mental health problems are being reported within this survey. And a general sense that a lot of people are struggling. Now, the range is between 14% and 60%. It's just a massive range. But it's high. And people talk about 1 in 4, 1 in 6. In a sense, it doesn't matter. It is a common experience to struggle with your mental health at work. So that's really, really relevant. And the last box is really just an acknowledgement saying, look, this is a big deal. This, whether we've just realised it or whether we've just focused a light on it and realised the extent, but this is mental health at work. And I'd rather talk about emotional well-being, but is a major issue. And we know it affects how businesses function, We know it affects your experience of your work. We know it affects, certainly the NHS, the patient outcomes. It is a big deal. Okay, so more context, but this is a loss of the context in some respects. So we've touched on the diagnosis issue, but really the diagnostic issue within mental health is far more tricky than it is within physical health. So there are some diagnostic categories that actually have very little what you'd call, or rather have slightly wobbly construct validity, i.e. are they actually a thing? PTSD, schizophrenia, certain personality disorders. So actually, at the top end of the more complex problems, there are lots of debates within the I guess the field about the validity of these concepts. But then you've also got issue of accuracy of diagnosis. So even if you've got a solid thing, and things like certain anxiety problems and depression are actually quite robust in terms of their validity, but they're often misdiagnosed. Normal psychological experiences are diagnosed and pathologized, which makes things worse. We know we have a problem with overprescribing, often because actually we have poor access or limited access to alternatives. So GPs are struggling and they want to help, so that adds to the complication. So you end up with a lot of people not quite knowing what they're experiencing, and maybe taking some solace from a diagnosis. But if that diagnosis doesn't give you a sense of, I guess, something beneficial or some prognostic capacity, it's not an awful lot of use. So I guess to me, diagnosis and mental health, tricky. Not the be-all and end-all, but we really need to be a bit more cautious about how we use it. We know that the biopsychosocial framework is the most powerful way of thinking about pretty much everything, but certainly for mental health. But we know that it's traditionally been very bio, and that's important. There's an evolution of a science there, but we are definitely looking to psychosocial factors where there is ample evidence to say these are the areas that we need to think about, because these will help. And ultimately, has everyone come across the stress vulnerability model? Okay, if you haven't, great. So it's a really elegant little model saying, actually, we all have some predisposing biological vulnerability to illness, physical or mental health. But nobody knows what it is. There's no genes being found to identify specific things, no matter what they claim. But we know that with a certain degree of stressors and a certain type of stressor, of course, there's no kind of elegant equation for everybody, but basically, because we're all slightly different in how we're stress sensitive, with the right stressor at the wrong time and the right amount, your vulnerability may be activated. So to me, that's a really useful way of thinking about mental health. We all have mental health. We're all capable of having mental illness, just as we're all capable of having physical illness. That's just, so it is about being human. And often we struggle with that. So that's context. Okay. So, looking at the evidence, now I could, again, bore you to death with some of the technological and statistical aspects of the evidence base, but I'm not, and I'm probably not the best person anyway. But whenever you come to think about the evidence, my advice would be put your skeptical consumer hat on, because there's a lot of people claiming a lot of things about a lot of things. And when you dig, what you find actually, one of the first things you get taught when you do any research modules is question, where did it come from, why? Question the methodology. So once you start digging, what you find is a lot of evidence isn't as solid as it appears, always biased, always, it has limitations. So everything has limitations. So we really, when you look at evidence, be skeptical before you become a convert, is my advice. We touched on some of the reliability issues. It's a minefield. It's a highly technical area. But don't let that put you off. Ask the awkward question. Okay? So let's look very briefly at what works outside of work, okay? From an evidence-based point of view. Now, certainly within the psychological therapies world, last maybe 40 years, I've seen a massive increase in evidence. Very little of it is preventative, interestingly. Most of it is reactive. Most of it is about the efficacy of treatments or interventions, which is fine. And I was talking to Phil earlier on, and actually that makes sense because, in a way, you can't control people's living variables, if you like. If you could end poverty, that would probably radically change things. So you get the opportunity to provide an intervention, and that's how psychological therapy evidence-based has generally evolved. Before NICE, NICE guidelines and that level of rigorousness looking at the research, you had a book called What Works for Whom, which if you want to have it's a really lovely book which pulled together the evidence base, probably early 90s, for psychological therapies. But the literature has evolved, the industry has evolved. We now have a really rich evidence base, a gold standard evidence base from many different types of psychological therapies, which I think is really something to be very proud of. And of course, research rigor is fantastic, but then you've got what happens in the real world. So what happens in the real world is often very different, certainly in terms of how you can generalize RCT outcomes, the nature of the demands of the work and the challenges of the clinical issues. As an ex-community mental health psychologist, I know that RCTs make no sense when you're working with complex problems and social deprivation, but we still have evidence and we draw it and we try to adapt and learn. But even at that level, you're trying to personalize the evidence, because there is no often very fixed way of deploying the evidence base. You have to use it in a quite I guess, informed way. And then we have the Matrix Cymraeg, which I think is our latest, certainly Welsh version of trying to work out what works for whom, using both, gold standard evidence, but also local knowledge. I think that's something to be really proud of. There will be iterations of that. It will evolve. So if you're looking at purely at what psychological interventions will help certain types of diagnostic categories, we have a good evidence base. How that then translates to services is a different matter, because of course we all know mental health services are Cinderella service. We don't have parity with mental health, with physical health. That's an ongoing debate. So what you find is if you're waiting for a year for a therapy, I feel often that's really unhelpful. So there are complications in the system. So that's the outside world. So let's look at the inside world, the world of work. Okay, so before we go there, I guess we need to think about work at work, and we need to think about what is our focus. Is our focus to help people, I guess, stay as well as possible, to thrive, to enjoy their working experience, i.e. prevention? Or is it to help them recover once they've fallen ill, once they're struggling? And I often, this dilemma, if you like, is really, really relevant to us, because often our services are geared up to reactively respond within work to people with problems. Now, we'll always need that, but I would argue that actually we need to shift that focus, or have both, but it's proportionality. Okay. So, what works at work? And I can't read this, so this is a memory exercise. So we know within the working environment, brief psychological therapies, 6-session therapies, which is pretty much the norm, I nearly swore there, they have very little evidence base, but we know they can be effective. My service is reasonable, outcomes are reasonably good, we know we help people, but if you compare it to the standard of evidence outside of work, i.e. in the clinical world, there is no comparison. So how do we know it really works? Now, how do we know our occupational approaches to returning people to work? Often they're time-focused or pragmatic. If you've ever heard the phrase, we need you 100% fit before you return to work, that's a complete farce, because nobody's ever 100% well. So often how we do these things is not well evidence-based. They're often intuitive, they're often kind of habitual. Sometimes they work, but it's not rigorous, it's not systematic. Can I read that one? Resilience training, bugbear of mine. Everyone wants to become more resilient, nobody really understands what it means, and there's a lot of opportunities to do training, to learn skills, not a lot of evidence that it works. Really lovely meta-review. 3 years ago, reviewed, I think, maybe 40 to 50 different programs for resilience training. No real significant improvements over time. So that's important. Mindfulness, really, really important, really useful, but actually within the work environment, there is no evidence to say that taster sessions, even brief sessions of mindfulness help. The only evidence is if you rigorously do the course, the 8-week course, and you practice it religiously, then it helps you. So most of us don't do that. So actually, again, what are we really talking about here? What else? Group training, psychoeducation, really helpful, but again, no long-term impact. So there's all these interventions that we can offer, but actually from an evidence base, if you go to the extreme level of rigor, they don't really hold water. I'll skip to the last one really. I'm just saying, look, there's a pragmatic position, is if you put all your eggs in a reactive basket, you will not address mental health at work. Okay? And what's more, you might make it worse. So this is a quote from a colleague called Jonah Wild, I know, who's a bit of a maverick, but actually is somebody who's very brave in speaking what she thinks. And her book is called The Social Psychology of Work. She'll appreciate me giving it a plug, but it's really solid, and it just offers a different perspective of this experience we talk about for work. If we push people that are pressured, overwhelmed, and struggling, and we offer them interventions that have no significant evidence base, we're just giving them more work. You're making it worse. So I'll leave you with that thought. So we've got a few more things. Okay, so if we just focus on reactive, what you're really saying is you are the source of the problem. Your illness is the problem. We'll fix you. We'll put you back on the front line, and everything will be fine. But we know that is not the case. We know that is not the reality of our work. So we really have to think a bit more systematically about what is people's experience of work, and be braver about saying, actually, some things are not acceptable, some things are permissible, and actually we have an evidence base to say, well, these are the things that will help you. Okay? So, another good piece of a document to really get your hands on is the recent British Psychological Society's review, literature review of wellbeing at work, i.e. what works. I can send people any of these documents if they want. And it basically starts with a statement saying, look, good work is a health outcome. It'll help you. It'll help you live longer. It'll help you be happier, be more satisfied, be more connected to your community. Bad work will harm you. Bad work actually is worse than unemployment. So that's my concern, is when work becomes a bad experience, it will harm you. And I think we're really at the cusp of grasping at that one. Okay. So, prevention. We know we can't sustain a narrative where illness is entirely a personal issue. We need to consider how to shift that experience and that narrative, how to change the experience of work. And we need a workplace which is healthier, psychologically healthier for people. Okay. Now, Mansel also mentioned the idea that as a social species, we learn to care for each other, to socially communicate and engage, which is fantastic, and that we're also hardwired to detect threat because it was evolutionary advantageous. Fantastic. That structure, that biological structure in our brain is still there. We've just shifted what we see as threat from, being eaten or being attacked by a neighbouring tribe to some of the social pressures and social experiences of work. They are now the threat that activates the brain's threat center, and work is full of them. Okay, I'll go into that a bit more in a minute. Okay, so we need to proactively change how we position ourselves and think about mental health at work, and that requires changing our narrative about what is mental health and what influence work has in either supporting it or undermining it. That's as simple as that. And there are 7 things you can do to improve people's quality of life at work, their well-being, and therefore their mental health. Okay? So, making work psychologically safer. Anyone had that feeling on a Sunday evening when you start to think about work? You might check your emails, and you start to get that slightly tight feeling in your stomach. Okay? So, a little bit of anxiety, probably not a bad thing. Sometimes that feeling is really, really deeply unpleasant. That is your threat center activating. And your autonomous nervous system is twitching and thinking, danger, danger. So when you start to connect that feeling with your work, you start off a vicious cycle. And that vicious cycle will only maintain unless it's resolved. So work becomes associated with threat, and then it just spreads. And it is really quite toxic. And these are the key things that activate our threat system, the things that will make you lose sleep, the things that will make you overthink work, the stuff that will get under your skin. Any experience of social shaming, being rejected or being cruelly treated at work, this stuff is like kryptonite to us. It is horrific. We are social animals. We're deeply sensitive to in-grouping, or rather out-grouping and social rejection and humiliation. And people kill people to avoid feeling shamed. And it might sound like an exaggeration, but it really isn't. It's a very deeply distressing emotion, is shame. But if you experience it at work, you're just essentially flooding yourself with toxins. Feeling disempowered or losing authority or losing autonomy. If you have a sense of loss of personal autonomy at the hands of somebody with a higher rank, it can be an antecedent for depression. Because it triggers a hardwired evolutionary system of passivity. Cool. Work is really dangerous at times. Next one, please. Okay. Increase purpose, people's sense of meaning and identity within their working environment, and they will work longer, harder, and be happier with it. I'm making an assumption that we're all NHS people here. We're not here for the money, it's here. This is why we're here. If you threaten that, you lose people. Next. Okay, a little bit of techie here. There's a really interesting model called the Job Demand Resources Model. Basically says if you really understand the psychosocial demands of your work, you can plan to mitigate them. And who of us understand the psychosocial demands of our work? We understand the physical demands, and HSC protect us from the physical challenges and threats and dangers, but who protects us from the psychosocial demands? So this is a model that's really helpful in saying, look, get that equation right, and you're getting there. Yeah? We're a social animal. The quality of our peer relationships, the quality of our teams, the quality of our collegiate relationships is absolutely essential. There's a lot of research on what makes a good team. You just go to the King's Fund. It's about size, it's about purpose, function, but actually the quality of your relationships. You don't have to be friends with everybody, but if you have a sense of discomfort, if there's eggshells to be walked on, it leaves you with something deeply unpleasant. We're social animals. We need that to be relatively harmonious. I like this, apart from the slide. I'm not so sure about the slide. But how often do you know what your role really is? So what is the work and whose work is it? It's a question posed in systems leadership theory. And if you've ever seen Ian MacDonald talk, it's a great way of illustrating this. But we often don't design our systems to think about actually, well, what really is your job? And how does that fit with everybody else's? And what resources do you need to perform? So you end up either overworked, underworked, or overlapping with people. Lack of clarity. We're a species that do not like uncertainty. So if your job is unclear around the edges, you're going to feel vulnerable because you might feel like you're going to be attacked. Little things like that can be really, really useful. Leaders and managers. This is so important that NICE have got guidelines. So I cannot understate the value and importance of getting... Now, there's a risk of saying good managers, bad managers. I don't quite believe that. But there are certain competencies, capabilities, qualities which we know correlate strongly with stronger well-being in teams and greater effectiveness in systems. I could go on for a long time, but that's where the psychosocial approaches to leadership comes from. It's a really rich area. Great. Fairness and justice. We are deeply sensitive to unfairness and injustice in our systems. And if you look at how your processes are designed, just think about how you design rotas, how you decide where people sit. Open plan offices. Everyone loves open plan offices. Great. Agile working. Fabulous idea. Until it starts to feel unfair. We're very sensitive to that. We design our processes often because they seem efficient and mechanical, but we don't think about the impact and how people feel treated, or is there fairness built in? And if we ignore that, again, you lose people, and people feel vulnerable. So, that's it. A few take-home messages. I can't quite read them, but, that they're pretty much about being skeptical about diagnosis or being a more active consumer of that, of diagnostic categories, of appreciating some of the systemic factors that you need to build into your working environments that would improve well-being. Don't give up on the reactive support and the intervention. Just be mindful of what they may be doing and messages they may be sending. Okay? And don't send people on resilience courses, because it doesn't work. It just makes them feel like they're weak and have failed. There are much better ways of building in team resilience. Team resilience is a much better predictor of people's individual capacity to cope. So focus on that. Right, that's it, I think.